Good evening, sir. Welcome to today's webinar brought to you by the Academic Council of IASO. This is the 46th chapter in the series of masterclasses. The topic for today would be adrenal tumors. I invite IASO President Professor P.K. Das to kindly welcome today's audience.
Good evening to all. I welcome to this 46th session of IASO Masterclass. As you know, this is a very interesting and very much accepted program, which is called as a flagship program of IASO academics. So we see a lot of enthusiasm amongst youngsters, young clinicians, as well as the teachers. So we thought we should continue in a great way and in whatever better way Dr. Subramanian Rao can do, and he is doing really well with the help of Dr. Srijan. And my respect to all the 4 journal advisors, Dr. Arnav, Dr. Sanjeev Misra, Dr. Rajguru Sharma, and Dr. Sadasivam. So I welcome all the participants, especially youngsters who has joined and logged in today. I hope you will enjoy the participation today. It's an adrenal tumor. We have chosen this because although it's a rare tumor, still the incidence is almost 3% beyond the age of 50 years. And there has been a lot of advancement in the concept of adrenal tumors. And the examiners are now more and more fond of putting the questions to the students. So this will be surely beneficial to the students at least, because a lot of concept has come at the genetic level and how to distinguish between benign and malignant tumors by radiological examinations, how dynamic CCT has come, dynamic MRI has come, and also how they can distinguish from benign to malignant tumors. So with these small words, I will just hand over to Dr. Rao, who can start the session. Dr. Rao, please.
I'll take it from Dr. T.S. Rao for now. I'll introduce our examiners and examinees in brief. We have Dr. Sathisan with us, who will be appearing as examiner as well as shall be delivering the expert talk. We welcome Dr. Sathisan. He was trained at Cancer Institute, Adyar, and was faculty there. He is currently the Professor of Surgical Oncology at Malabar Cancer Center, Kannur. He is the director of the institute, and his areas of interest include urological malignancies, musculoskeletal oncology, and pelvic oncosurgeries. Welcome, sir. The moderator for the session today shall be Professor M.S. Ganesh, who's the professor and head of surgical oncology at Vaidehi Cancer Center, Bangalore. He's a senior surgical oncologist with over 26 years of experience. He's an alumnus of Cancer Institute, Adyar as well. And his past experiences include being the assistant professor at Adyar, being the senior consultant at Dharmashila, Delhi, as well as Fortis Hospital, Delhi. He has multiple publications in indexed national and international journals, and he has been active in conducting trials in molecular and clinical oncology. He has keen interest in head, neck, and soft tissue neoplasms. We welcome you and thank you for the effort in preparing the cases for today, Professor Ganesh.
Thank you,
the examinees today shall be Dr. Akash Guha, who's a resident in the Department of Surgical Oncology at Dr. B. Burua Cancer Institute, Guwahati, and Dr. Akhilesh Chittineni, who's a resident in Department of Surgical Oncology, MS Ramaiah Medical College, Bangalore. A few instructions for the upcoming session. For the examinees, we expect you to give to-the-point answers. So if you don't know something, please pass on it to your colleague. It will save us time. For our moderator, there's a special request that we request you to address the examinee by their name when you address a question. This will ensure that they know who is supposed to answer, and will also avoid some confusion. We also request you to ensure that both of the students get equal opportunity to answer. For both our moderator and examiner, in interest of online viewers, both who are live today as well as who are viewing this on YouTube at a later date, we request you to give the expected answers to the questions that remain unanswered or have been incorrectly answered by the students. We'll be doing the timekeeping from our side, and we'll be reminded Professor Ganesh at 30 minutes and the conclusion of case discussion, which would be 60 minutes over chat. With that, I would like to invite Professor Ganesh to kindly share his screen and take hold of the first webinar session.
Yeah, thanks to Academic Council of IASO, Dr. Subramanyeshwara, Dr. Shukla, and IASO official body. We'll go ahead with the case. So the first case is like this. For the examinee, he's a 15-year-old female teenage girl who came with the chief complaint of hot flashes, headache, of 2 years duration. She also had a history of palpitations for 2 years. Unfortunately, she developed a blindness secondary to severe hypertensive retinopathy at her native place. Then she had also a history of stroke way back 2 years back, and a history of seizures 2 years back. All this went unnoticed in a young girl like this. And she came to us for further management in Bangalore. So this is a history in summary of this girl. Let's right away go to the examinees. We'll ask Dr. Guha now. If you get a child like this, 15-year-old girl who's a young hypertensive with episodic attacks of hypertension and also a severe history of hypertensive retinopathy and stroke, what would come to your mind? What would you be thinking of? What are the possibilities you will engage?
Sir, first, I will think that there is an chances of pheochromocytoma will be high in this patient, sir.
Right away, you would think of pheochromocytoma, or are there any other common possibilities? Would that be a common cause of hypertension in young people, or would you specifically think of pheochromo due to some reason?
Sir, pass.
Dr. Akhilesh, can you pitch in?
Sir, it could be anxiety, neurosis, or panic attacks. Could be pheochromocytoma.
Which leads to organic deficits like this, hypertensive retinopathy, stroke due to panic attacks, anxiety, quite unlikely, right?
Yes, sir.
So we would just put this to our examiner and ask his opinion, what he would come up with his suggestion. If there is a young child like this with severe hypertensive episodes, what are the likely possibilities, common possibilities? Sir, Dr. Satish.
Yeah, thanks, Professor Ganesh. Thanks. I think, to both the examinees, see any young patient, any patient, this is something like almost like a malignant hypertension because it has produced an end organ damage in a very short period. This is 2-3 years time it has produced. So there are, apart from your pheochromocytoma, there are other causes which you have to think. It could be a renal cause, it could be a renal vascular cause, renal artery stenosis, or it could be even a cardiac, for example, coarctation aorta is known to produce. Certain drugs can cause, especially certain, probably not at this age group, maybe a little bit more cocaine, hyperusage can cause such things. then some already hypertensive was withdrawn medications that can cause. Sometimes a cerebral injury can cause similar things. Any head injury or something it can cause, especially in ischemia infarction, a scarring, it can lead to this things. So there are, or even other hormonal disorders like Cushing syndrome, Conn syndrome. All these are potential possibilities. So just looking at only pheochromocytoma may not be enough. I think we have to rule out other reasons. So a detailed history is needed in this case, and any familial syndromes are available. So that's also that particular history we'll have to take it.
Absolutely. I think he made it the point. There are common causes. I would just add even thyroid issues could cause hypertension. So, but one thing, Dr. Guha, you are right in one point that it was episodic with severe episodes of hypertension. Okay. Such things are usually seen with pheochromocytoma. So you're right there. So let's go to the next slide. So with this history, we do engage a possibility of pheochromocytoma in a young girl. Some more things about the history. There was no significant past illness, no significant family history of anything which could throw light on the present condition. She had a normal menstrual cycle. No treatment history of significance except for hypertension, for which she was on medication. She was managed for stroke and she was managed for retinopathy, but unfortunately she lost both of her eyes, vision, I mean, and then she came here. So that was a history in brief. Dr. Akhilesh.
Yes, sir.
Would you ask any other questions of relevance in history to just look at some associated conditions? Young hypertensive.
Sir, with related to could be a renal cause, so I would like to ask about her any urine output, renal failure, swelling of limbs, or decreased urine output.
Yes.
Then, if it can be any familial history, flank pain, or could be associated renal cell carcinoma in a syndromic cause of pheochromocytoma.
Correct. So you would also look for familial causes, right? Which there could be association in the family or associated disease condition. Correct. Would you come to any specific history apart from renal? Assuming there could be a familial element in a young girl like this, would you look for any specific other history in this girl?
Like any thyroid, like Men's syndrome, or
so what exactly would
medullary thyroid carcinoma in the past?
Would ask for any thyroid swelling?
Thyroid swelling, neuromas in case of men to be.
Would you ask for any increased instance of stone formation, calculi, repeated calculi?
Yes, sir.
You would, right?
Yes, sir.
Okay, fine. So that would sort of summarize how we would look at history in a young patient like this. Dr. Satish, you would like to add something here?
Yeah. I think one thing, Akhilesh, because you said about renal, conditions, and one thing also, the glomerulonephritis that can also produce hypertension. So that is also one of the aspects. Second thing, as I said, because when it goes to renal failure, you other things which you said. And then, you can look for, other history of any previous surgery, some tumor which has been removed or anything. That is also an important aspect because of some non-functioning tumors, paragangliomas, also young patient, because the syndromic things is quite normal. It can be found. Yeah, rest of the things I think you have covered.
Let's go to examination. She was a young female patient who was well built and nourished, ECOG status 2. Visual acuity was 0 in both the eyes. There were no other significant findings in general examination. Her BP static was 160/96 millimeters of mercury. There was nothing in head and neck significantly finding. The breast and chest area did not reveal any abnormality. There were no masses palpable per abdomen. There was no free fluid in the abdomen. Spine and other areas within normal limits. Gynae examination was not done due to unmarried status of the child. So this was the examination findings of this. Dr. Guha, would you like to add something in the examination apart from this? Young hypertensive who had, say, malignant hypertension. Are we complete here, or would you pitch in with something else?
Sir, we will do a very thorough examination of neck examination for any lymph nodes, sir. And
We said that head and neck, bar face is within normal limits.
sir, we will look after any other thorough full body examination for any pigmented patch,
Good.
any
Good.
neurofibroma,
Yes.
or sir, or any other lesions. Otherwise, that could have been missed.
Okay. Okay. So I think that would as well sort of complete the examination part, because we don't, there is nothing else to add. So Dr. Satishan, is there anything being missed here in the examination which you would add up?
Yeah, already some of the hormonal syndromes which talked of, for example, Cushing's and such features, any virilization. So those hormonal overactivity things which we can look for.
Correct. Correct. I think coming to specific suggestions, I think in a young female like that, you would look for virilization symptoms.
Yeah.
Yes, that's a specific point which is put forth there. And yeah. So let's go to the next slide. So this is how she was worked up. I'll put these points and then you can say whether we are missing it something here. This will be for Akhilesh.
Yes.
The young team was worked up in the Department of General Medicine. She landed up for hypertension, typically like in many places. She was managed there. They did a CBC, which was normal. They looked at renal functions the way we were suspecting. Urea, creat, and all other factors were normal. Liver functions were normal. Echo revealed a mild concentric left ventricular hypertrophy. She went for ophthalmological checkup, which revealed a bilateral optic neuropathy, and they said that it is due to hypertension, and then acuity was almost zero. They couldn't make out anything. Serum electrolytes were within a normal range. Thyroid functions were normal, and they also checked for, I think, TPO antibodies within normal limits. Are we missing anything here in the general checkup like this, Dr. Akhilesh? Patient is here with you. Would we do something else in general terms, apart from specific things we look for malignant hypertension as a cause? We had some diagnosis in mind. We'll go there. Is there anything else we could do here? She was in general medicine department. She didn't come to a specific department at this stage.
No, sir. Baseline blood investigations. That's
But
also.
Dr. Guha.
So I think it's sufficient, sir.
Okay. We'll ask our examiner whether anything else in general checkup, summary, workup, you would like to add.
Yeah, this is, I think this is adequate, except for that, the hormonal things which we discussed earlier. But anyway, that is, that is other clinical features are not there. That is the reason it may be. Why they just stopped at this. Yeah.
Let's go to the next. Since she was a young hypertensive, I think they naturally, the way we thought, they wanted to look for renal pathology first. They suspected renal pathology, and they wanted to look for the status of kidney and also the status of renal vasculature. Incidentally, it showed a suprarenal area, showed a 53 mm into 32 mm isoechoic mass, which was well circumscribed. Both kidneys were of normal size and echo texture. And renal vascular Doppler did not reveal any pathology. There was no vascular flow issues or narrowing of the vessel. And there was nothing like that to suggest that it's a renovascular thing. Kidneys were of normal texture and echo texture, no chronic CKD there. They picked up a suprarenal mass of 5.3 centimeters into 3.2 centimeters. At this stage, we'll come back to Dr. Guha. Anything else ultrasound should be picking up there, or you would like to say that you would be, this is okay to go further? There is a specific indication of what is there in the ultrasound, but is there anything else you would like to add here in ultrasound? It's a very common investigation done. What else you would like to know here? I'm just putting the report as was reported at our place, as we got it, like in many hospitals, what they do. You can add up as a postgraduate student, you can tell what else you would like to know.
Sir, sir, I think it is sufficient. We can go ahead with next investigation, sir.
Would you, Dr. Akhilesh?
Any other lesions in liver?
Correct. Apart from that, anything more important? It talks about right adrenal.
Opposite side,
Correct. You would like to know about the opposite adrenal as well, right?
Yes, sir.
And if you want to look for some other markers, where would you look for on ultrasound?
One would be liver lesion. Any liver lesion on bladder.
Now, anything, in the around aorta or something you wanted to look for?
Yes, around the organ of Zuckerkandel, any extraadrenal lesions at the level of bifurcation.
Yes.
Bladder.
So you,
Yes,
correct,
bladder.
correct. So you will engage a possibility of opposite adrenal as well as extra-adrenal lesion, correct?
Lesion. Yes.
So there's a common way of looking at ultrasound when you know exactly you are pointing at some diagnosis. What biochemical test that you have, you ask with this? You have a young hypertensive. Ultrasound shows a right suprarenal mass, and all other things point to probably a pheochromocytoma. What biochemical test will you ask to confirm your diagnosis?
Sir, as I would like to go for rule out hypercortisolemia in this patient, and also do an aldosterone and renin test, along with other test for ruling out pheochromocytoma, like plasma-free metanephrine in this patient, sir.
So you said you look for hypercortisolemia and hyperaldosteronism first, and then come down to pheochromocytoma testing, correct? Dr. Akhilesh, would you agree for that? Yeah, you want to say something. You wanted to tell something.
Sir, I will do all these three investigations together only, sir, as it is an incidentaloma. So we will go and give the same this investigation all together, sir, at the same time.
Would you call this as an incidentaloma?
No, sir, not incidentaloma, sir. After workup only we are getting, but we have to rule all these three out before we can proceed further, sir.
Okay. So I'll ask Akhilesh, would you consider a possibility of hyperaldosteronism as a cause of hypertension?
Sir, his potassium level is normal. There is no hypokalemia in baseline blood investigations.
Very good.
And clinical history suggests more towards malignant, more towards pheochromocytoma with hypertension. So I would like to rule out pheochromocytoma first, and then if it is negative, do a serum aldosterone and.
Absolutely, that's bang on. Because electrolytes have become normal limits, which is highly unusual for a aldosteronism, right?
Yes.
Yeah. So, Dr. Guha, coming back to you, suspecting it to be a pheochromo, what would be the test you would like to ask? Let us take a common test. Let us not get theoretical. Let us say that this patient is with you. What will you ask?
Sir, I couldn't get you. It's muffled. The voice is a little bit muffled. Can you repeat, sir?
What specific test for pheochromocytoma would ask? That's my question.
Sir, I didn't get you still.
Not able to hear? Am I not audible to others?
Sir, yes, you are audible.
Yeah. So what specific test you would do for pheochromocytoma?
Sir, for pheochromocytoma, I do a plasma-free metanephrine, sir.
Okay.
And in that, we will see for normetanephrine level and metanephrine level. And if the values are increased more than 4 times the lab values, it is highly suggestive of pheochromocytoma, sir.
So you look for plasma metanephrine and normetanephrine.
Yes, sir.
Anything else? Suppose you don't have these tests at your place, you are rather at a remote place, they say it is not available. What other tests you could look for?
So 24-hour urinary fractionated metanephrine.
Good. Okay. What else? Suppose even that is has to be outsourced. Some other tests are there at your lab, which is easily done. No, though not that specific, which was commonly done at some point of time.
VMA testing, sir.
Can be done, right?
Yes, sir.
Dr. Akhilesh, would you add something else?
No, sir. By specific to pheochromocytoma would be this one.
Sir, Dr. Satishan, is there anything else you would suggest?
No, urinary and plasma metanephrine, because these are both sensitivity and specificity are almost similar. And I think this will give us a small diagnosis. And free catecholamines is another thing, but that is again, it depends on availabilities is one of the issues, something I found. And one more thing I just want to tell Dr. Akash, because when we talked about hypercortisolism, then I think this one we have to look at it whether she's diabetes or not, sugar levels are elevated or not. That is one thing. I think a previous our test did not show any hyperglycemia. That is what I understand.
Yes, sir.
Correct.
Okay.
Okay, so I think that sums up the common tests. To sum up, the plasma, metanephrine, and normetanephrine remain the most important tests, the most sensitive and specific. Catecholamines can be done, but they are not easily available, and again, they are not the best tests to be done in comparison. Okay, so these were the values. I think at our place, the general medicine department went with 24-hour urinary metanephrine, which was like this, and urinary normetanephrine were the ones which was raised. And they also checked for the viralization markers, DHEA levels, which were not elevated. Cortisol was not elevated. And I think we commented on the other test. The endocrinology department tested for plasma metanephrine, which was elevated, and normetanephrine. Both were elevated. I think they checked in the when the patient went to endocrine department from general medicine. So these were the tests done at our place. What would be the provisional diagnosis, Dr. Akhilesh? Now,
most probably is the pheochromocytoma of right adrenals.
you would suspect a pheochromocytoma.
Yes.
Okay, fine. Dr. Guha, would you check for further imaging here, or you're okay to act now with this test and with this imaging?
Sir, I'll do a non-contrast CT along with a dynamic CCT in this patient for a better characterization of the tumor, sir.
You would like to do a non-contrast CT in a, why would you want to do a non-contrast CT in this patient?
Sir, it is sir non-contrast, sir, because sir, contrast enhanced CT, sir. I will do a contrast enhanced CT, sir.
Isn't it?
Yes.
Here, I don't think there is any real role for a non-contrast CT. Are we right?
Yes, sir. Yes.
You almost have a provisional diagnosis there of what it is.
Yes, sir.
You would like to only know other factors on imaging, okay?
Yes, sir.
Okay, so you would want to do a contrast CT. Dr. Akhilesh, would you accept with that, or would you like to get some other thing?
Yes, sir. I would like to do a contrast enhanced CT abdomen with adrenal protocol.
Okay. Sir, what does Dr. Satishan say here?
Yeah, I think this anatomical imaging, because it's more than 5 centimeter tumor, right? And so I would suggest to do a CT of the contrast CT of the chest, abdomen, and pelvis, because we have to rule out other tumors, because there is always a chance of associated paraganglioma elsewhere, young patient. Second thing is that the malignant pheochromocytoma can only be diagnosed only if metastases are there. So whether it be malignant or not, we don't know. So this imaging is mandatory. And apart from that, for example, there's no other lesion elsewhere, then probably this might be enough. But I think it's always advisable to go ahead with one nuclear medicine imaging test. Probably, I think the next slide comes up, I think, this one.
So, Dr. Guha, when would you suspect malignancy in a thing like this? Suppose you have an adrenal mass like that. When would your suspicion be more towards malignancy?
Sir, if the mass is inhomogeneous, borders are ill-defined, there is a signs of invasion of adjacent structures, and moreover, if there is distant metastasis, I will suspect malignancy.
Distant metastasis, irregularity, you said, inhomogeneous appearance. Anything to do with size, Dr. Satish was talking about? Is there a size criteria to have
Sir, there is a size criteria, sir.
Yes.
If size is greater than 6 centimeter, that it points more towards in favor of malignancy, sir. And
what percentage of adrenal tumors are likely to be malignant?
Sir, if it is size 6 centimeter and above, almost 25% of cases are found to be malignant, sir. And if it is greater than 4 centimeter, percentage of malignancy is seen in 10% of cases.
Dr. Akhilesh,
Yes, sir.
extra-adrenal or adrenal, which is a more common site for malignancy?
Extra-adrenal is more common.
Good. So I hope this is playing. Is it playing?
Yes, sir.
Yeah. So you just, I think this would leave to Dr. Akhilesh. You can answer this.
May I intervene a moment?
Yeah.
Yeah. So those, Dr. Akash, generally infiltration, local infiltration doesn't suggest malignancy in a pheochromocytoma. Pheochromocytomas is known to produce a lot of desmoplasia around the tumor. Sometimes we find it difficult to resect the tumor. It might show some adherent to the vessels, but we find that it's a benign tumor. It could be. So the only sign of malignancy in a pheochromocyte is metastasis. And if once the tumor is removed, or you have the genetic mutational analysis of ATH beta, so there it might show again a chance of having malignancy. Then, as I said, this paraganglioma, the tumor elsewhere, that is again, and it indicates a high risk for metastasis, high risk for malignancy. Yeah.
Totally agree. So here is a CT. Just tell me when to stop, I can stop it. This is for Dr. Akhilesh.
Yes, sir.
You can see that?
Yes, sir. Right side.
In the first look of it, what do you think about it? Some gross opinion.
Yes, sir. It is a well circumscribed,
Very good. Very
homogeneous.
good. You would call it homogeneous?
It is mixed density. Yes.
You won't have, it's not definitely homogeneous.
Yes,
But
sir. There is a
well circumscribed.
well circumscribed.
Yeah.
Right kidney looks normal below.
Right, well circumscribed, right suprarenal lesion.
Right suprarenal mass. Yes.
Anything else you can comment on? This is a contrast CT.
Yes, sir.
So what would you talk about in a contrast CT, in a tumor like that in suprarenal?
If there's any necrosis, central necrosis or calcification.
More importantly than necrosis, what are you looking for when you have given a contrast for a
Invasion of any tumor thrombus in the renal or adrenal veins? IVC.
Dr. Akhilesh?
Yes.
When we give IV contrast in a tumor like this, what is it that we are looking at?
Enhancement of the lesion.
Correct. Correct. So what about enhancement there? Which areas are enhancing?
It is peripherally enhanced more than the center.
Very good. More of peripheral enhancement
More of
than in the
yes,
center. Okay, a rim of peripheral enhancement, well circumscribed suprarenal tumor.
Yes, sir.
Okay, abutting the liver there. Okay,
Yes.
And no other the IVC was compressed, which was expected there. Apart from that, what else you will look?
Look for any other liver lesions, right kidney. If it is.
More importantly, before you go to metastasis, what else you would look at? We discussed this when we discussed ultrasound.
Opposite side suprarenal.
Correct. What percentage would you expect opposite adrenal to show a lesion?
10%.
Very good. Very good. So you would look there.
Yes.
I would just tell in this patient, the imaging was reported as something going across the aorta. I mean, across the midline. They did suspect that there could be something extra adrenal, but ultimately it proved to be, we went down and had to discuss and find that there was nothing there. Because when we were trying to manage this patient, we wanted to be sure where all the lesions are in this patient. Ultimately, the diagnosis here was confirmed that it was related only to right adrenal. Okay. Yes. So Dr. Satish, you would like to put something here, add something here?
Yeah. No, I think you have covered most of things. Yeah.
Gotcha.
Too much I have to add. Yeah.
No, I just put these. If the videos are not playing, we'll just skip this. This was a report, a large, well-defined soft tissue attenuating lesion in the right suprarenal region, showing a peripheral rim enhancement. Tumor measured 53 into 45 centimeters. There was a centripetal enhancement with a significant washout after 1 minute and 15 minutes. And there was no necrosis, and the lesion was seen abutting adjacent liver segment and also compressing the IVC. Planes were maintained. Left adrenal was normal and other structures are normal. They gave it as differential to be considered as lipid poor adenoma and pheochromocytoma. Okay, I think when the CT was asked, the information didn't go to them that the metanephrine levels were raised. So I think it was not conveyed to them. So they gave a diagnosis like this, but this is the CT finding. So a final diagnosis of a pheochromocytoma limited to the right supraadrenal was made. I think, when do we suspect familial inheritance, Akash?
So 1 minute. Shall I ask one questions to the?
Sure.
Yeah.
Go on.
So the differential diagnosis is given is a lipid poor adenoma, right?
Yeah.
And a pheochromocytoma. Is that CT? By CT, can you differentiate that? Is that possible?
No,
Yes,
sir. No, sir. By CT scan, pheochromocytoma cannot be diagnosed in a CT scan.
Right. But there's a differential diagnosis of lipid poor adenoma. You know about adenoma, that is one of the things you wanted a non-contrast CT, because that is what I think you wanted to look at it, whether it's adenoma, isn't it?
Yes, sir.
But when there are two types of adenomas, one is lipid-rich adenoma, another one is a lipid-poor adenoma. So in lipid-poor adenoma is a problem, because to differentiate between lipid-rich and lipid-poor, it is difficult. It is, but lipid-poor and other tumors we have to differentiate. But using a contrast CT, is it possible to differentiate that?
Yes, sir.
Yeah. How?
You can do the absolute washout and relative washout.
Yeah, washout analysis. Good. It looks a washout analysis. So it's a rapid washout analysis. You can see lipid poor adenomas, but in pheochromocytoma, generally it's a slow washout.
Yes.
Okay. Thank you.
I think we suspected this. When do we suspect familial inheritance? Means it is not a sporadic pheochromocytoma. When do we think it is likely to be a familial cause? Quickly.
Sir, if family history is positive of any other malignancies like medullary thyroid carcinoma, any other renal carcinoma, neurofibroma in the patient, and there can be also hereditary paraganglioma and pheochromocytoma in the family also. Then you will go for this familial.
So all the familial syndromes, if there is a evidence, you would think of family. Anything on clinical grounds which would suspect it to be a familial origin? Multiple tumors.
Young age, multiple tumors.
Young age, multiple tumors.
Multiple tumors.
Right? They would arouse a suspicion, not that we base fully on these things, but it arouses a suspicion of it being familial syndrome.
Another thing is bilaterality, multiple tumors. Yeah, so that's especially a paraganglionoma. That is also suggests that. Yeah.
This would it, sir. Is there a need for radioisotope imaging in this condition? Let's not go theoretical. We'll discuss here. Does the radioisotope imaging help in this situation? Should we do it or should we not do it? Dr. Akhilesh.
Sir, if the contrast enhanced CT does not show any lung or liver mets, bone mets, no need for no level 1 evidence to say there's a PET is required or a nuclear imaging.
So you won't advise a radionuclide scanning here.
No, sir.
Dr. Guha, would you accept with that?
Sir, we can do radionuclide study for future purpose, sir, for baseline.
Patient is with you. Would you do or won't you do this patient? Patient is with you, admitted under you. Would you ask for a study, nuclear medicine study, or you would go ahead with your treatment?
Sir, if there are no any other lesions in doubtful lesion in lung or liver or any other place, we won't go ahead with the FDG PET CT, sir.
So both of you say it's not needed. We'll ask our examiner what is his opinion on that.
Yeah, generally it is not needed, but when you suspect that this particular tumor is likely to have a chance of metastasis, yes, in those situations, yes, we can go ahead and do that. And so in this case, and we need not have to do it. But as I said, the option is there. We can keep it. For example, if this patient develops a metastasis or something, in that case, probably it might be useful, but it is not mandatory in this situation.
Totally. I would also agree with that, that in this patient, probably there is no indication to do a scan like that. If the values, biochemical values were equivocal, or if there was a doubtful metastasis, yes, we would ask for a scan, not in this patient. Would you medically manage this patient or would you directly take up for surgery, Dr. Guha?
Sir, first we have to preoperative management should consist of taking control of the BP, sir. And for that, we will give alpha blockers first initially. And after adequate control of the BP, if there is tachycardia, we will add a beta blocker. Then only we will take the patient for surgery.
So you would add a combination of alpha and beta blockade before you undertake surgery, right?
Yes, sir.
Dr. Akhilesh, would you add something else or that is enough?
I would also add salt loading along with alpha beta blocker and hydration.
You would like to hydrate and salt load.
Yes.
Sir, Dr. Satish?
Yeah, I would like to ask him what type of alpha blockers you will use it. You will use it selective or is non-selective permanent blockers?
Sir,
Drug? Yeah.
non-selective permanent blocker is better. Phenoxybenjamin is better than selective alpha blockers.
Okay, what is the problem with phenoxybenzamin if you use it?
Sir, it is, sir, I don't know, sir.
Yeah. I think
Hypertension.
Yeah, one is postural hypertension. Second thing, it produces headache.
Okay.
And another thing, some side effects are more in the phenoxybenzamin. And another thing, tachycardia is more.
Yes.
Produces severe tachycardia. So that is one of the problems of phenoxybenzamin. But if you're using anybody who wants to take Akhilesh, will you use a alpha 1 blocker?
If phenoxybenzamin is not available, I would like to use a selective prazosin like alpha 1 block.
Yeah, prazosin. Yeah, that is fine. Okay, then beta blockers. Why do you want to use beta blocker?
If the tachycardia is not controlled.
Yes. One, it is not controlled. Second thing, tachycardia. Tachycardia is another area which we use it. Will you use calcium channel blockers?
The BP doesn't come down in spite of using both alpha and beta blockers, we can use a calcium channel blocker.
Okay. So will you have any cutoff for your any target BP or something which you want to aim at before preparing the patient?
A sitting position BP of less than 130 by 80.
Very good.
Excellent.
Yeah. Lying down posture rather than sitting is lying down posture. Supine BP. In standing?
Standing, it should not be systolic should be more than 90.
Yeah, that's true. It should not come down less than 90. So this is the target BP which look at. Okay, good. Very good.
So this was what was done at our place. They put on prazosin and metoprolol. Paroxysmal tachycardia was there and hypertension was persisting. So they increased the beta blockade and a dosage of prazosin and added amlodipine for her, which got it under control in a 13-day period. And then she was ready for surgery. How this case should be surgically managed? We'll go to each one of the examinees. Dr. Guha, patient is with you. What exactly would you tell the patient you would be do for her?
So first, patient should be before we should prepare the patient preoperatively, as I have said earlier, sir. In the OT,
Done.
patient,
That is all done.
An intraarterial catheter should be done. Intravenous catheter should also be done. After that, we will start the OT first. As it is a we are we will go for a open surgery in this patient, and we will do a thorough peritoneal inspection first before proceeding to the excision of the tumor, and we will mobilize the colon in the right side, and after that we will approach the adrenal glands. We will first take vascular control of the tumor, and before ligating the vessels, we will try to first ligate the vein, then the artery, and we will inform the anesthetist that we are ligating the vessels, and then we should ligate and take out the tumor in block. Try to take out the tumor in block.
Dr. Akhilesh.
Yes. Pheochromocytoma laparoscopic adrenalectomy should be done, so it's a standard of care. If it is in experienced hands, if it is not available, open adrenalectomy is also an option. Either it could be a transabdominal approach or a loin approach, and no touch technique should be adopted, and just before the ligation of the renal veins, anesthetist has to be informed regarding drop in hypotension, which can happen, so that they will adequately preload the patient.
So I think I will ask the examiner here to sort of moderate your approach. Question one is, would you choose laparoscopy or open approach in this patient? What would the examiner ask you in this?
Laparoscopy, yeah, laparoscopy would be, considered as one of the standard in case of pheochromocytoma, especially a small tumors. If there is no, addition or infiltration, you can see in a CT scan or anything. Open is also equally good, and that is one. Second thing is that apart from the examinees, what they said about the preparation, intraoperative preparation, yes, we need central line and we need arterial line, and at the time of intubation, the most important thing, we need a very good experienced anesthesiologist. That's very, very, very vital. And I would rather pose this case as a first case. All pheochromocytomas always is posed as first case, and try to avoid fight with your wife on the previous night. Then it is something, with a good frame of mind we have to go in, because it's one tumor which produces a lot of tachycardia and hypertension to all the people who are operating on and also assisting. That is one. So, and intraoperative vascular, expansion that has to be taken care, regular monitoring, and these things are important. And in the laparoscopic approaches is, that is considered as currently it is considered as a minimal invasive, is currently considered as a standard in easily resectable small tumors.
So Dr. Guha, I think you said open surgery with the concern that the size is bigger. Am I right?
Yes, sir.
Am I correct? You use
Yes,
size
sir.
as a criteria.
Yes, sir.
You may be partly right, but I think being looking all like a benign condition and then a pheochromocytoma, the laparoscopy would be a standard approach even for that size. Correct?
Okay.
Yes. And then technically, what are one or two important things? I think Dr. Satishan told them. If you are sort of operating through laparoscopy, what are one or two key things which you will do? Of course, anesthesia management is critical. That is another part. They will be taking care. But what is it that which is going to be sort of one or two critical events in your surgery, in laparoscopy, adrenalectomy, for a pheochromocytoma? Right-sided tube.
Sir, duodenum should be identified first and protected, sir. There is a chance of duodenal injury in right-sided adrenal tumors. Then it should it should be done in a no-touch technique, sir.
What do you mean by no touch technique?
Like a tumor should not be handled much. If the tumor is handled much, there is chance of hypertensive crisis or fluctuation in BP might be caused due to too much handling of the tumors.
So minimal handling.
Minimal.
So, I'll put this question to Dr. Akhilesh. How would you prevent minimal handling, Dr. Akhilesh?
That is actually a difficult one. And one thing is that I will dissect the adrenal of the kidney first. So that is the kidney will be brought down because once it's taken off, and posteriorly will go and take the adrenal vein. Vein is something which we have to take care of first. Once the vein is taken care of, then I think the most of things is done. So that is one of the things.
So probably, as I put correctly, you would at the earliest would like to get the adrenal vein clipped, correct?
Yes.
Because you would like to prevent the flow of
Catecholamine.
into the system. Okay. For that, I think one or two key important things are you need to get a good exposure there. A proper liver retraction is very, very essential. Correct? Yeah. This case was done through laparoscope at our place, and then you want to have a good exposure, early clipping of the adrenal vein. Okay, and then get off all the vasculature and then remove it. Okay, and the key events are the adrenal vein on the right side being a short and stumpy one. You don't want to injure the cava or sort of have a bleeding there, isn't it? These are the 2 or 3 important steps for a right-sided adenectomy. I think if there are no other inputs from the examiner, we should be closing this case.
Yeah, sure. Okay, well done, Akash and Akhilesh.
Done very well. I think this, to summarize, this patient did undergo laparoscopic adenectomy and was discharged on 7th day. She was actually hypotensive post-op, and which had to be managed by a low-dose noradrenaline, and then which picked up after 24 hours, and then she was discharged on 7th day. I think due to paucity of time, we won't go beyond this here. And let me go to the second case. Am I visible now?
Yes, sir.
Okay. So this is a second case, probably. Dr. Shukla, how much time we have left?
It's 15 minutes.
15 minutes, right.
Yeah.
So we'll go like this. 70 years female, non-diabetic, hypertensive, complaints of generalized body pains and weakness, daytime sleepiness, snoring, occasional burning, micturition, blurring, all non-specific symptoms. She was a diagnosed case of carcinoma breast, which was diagnosed as T2N0M0, ERPR positive, HER2 negative, and a left-sided modified radical mastectomy was done 1 year back, and then she was on letrozole. It was done 5 years back, 6 years back roughly, and she was on letrozole, and the last follow-up was on January 2022, which was normal. That was her past history, which was significant. There was no significant family history or any other relevant past history. Patient was ECOG1 on examination. General physical examination did not reveal any significant findings. Operated site, left-sided chest wall, axilla, opposite breast and axilla, bilateral supraclavicular areas were normal. Abdomen did not reveal any masses. There was no organomegaly or any free fluid. For vaginal examination, there was a retroverted uterus and there was no deposits in the pouch of Douglas. Rectal examination was normal. So here is a young lady who came with non-specific symptoms and then who was sort of followed up for symptoms after a 6 years period after undergoing a primary treatment for breast cancer. At this stage, there was no suspicion of anything. So patient had a basic investigation follow-up. Lab investigations were normal. X-ray chest did not reveal any pulmonary lesions or effusion. Mediastinal area was not widened, nor they revealed any abnormality. The layout was normal. Visualized bony areas in the X-ray chest did not reveal any abnormality. An ultrasound abdomen was done as a follow-up procedure, sort of a screening investigation in a follow-up. Liver and spleen was normal. There was no free fluid. It picked up a incidental 4 into 2.5 centimeter, well-defined solid mass in left adrenal area with mixed echogenicity. Bilateral kidneys were normal. Atherosclerotic aorta was there. Nothing else was significant in the ultrasound. The impression which was given was in a known case of carcinoma of breast, the lesion suggests adrenal metastasis. This is where we stand in this case. This is for Dr. Guha. What is our next step here? What should we do with this patient?
Sir, in this patient, we should first give a general blood investigation, like complete blood count.
Done. All were normal.
Sir, in this USG, then after that, we will do non-contrast non-contrast CT along with dynamic CCT of the abdomen, or we can go ahead with the FDG PET CT in this patient.
What would you prefer?
Huh, sir?
Which investigation would you prefer? Contrast CT of abdomen or whole body PET scan?
Sir, as the radiologist has suggested that it is a case of metastasis, I would like to go ahead with the FDG PET CT of the whole body.
Apart from radiologist, do you still think it could be metastasis only, or it could be something else, or primary thing? Or you still think it is metastasis?
Sir, from the history, there are signs that it could be a second primary also, sir. Like a patient has a history of earlier breast cancer. Patient has history of burning micturition. Patient is hypertensive and diabetic. It can be there can be a adrenal. This can be an adrenal adenoma or adrenal cortical carcinoma also.
Okay. I'll just stop you here, Dr. Akhilesh.
Yes,
Would you
sir.
think it's a second primary in the adrenal, or would you think of metastasis? Which would be more common?
Already previous history of carcinoma of breast, more likely would be a metastatic lesion.
Still, you would think it to be more likely to be metastasis. Would our examiner add concur with this view or with the first view?
Yes, I agree with Akhilesh, because that is one thing which I agree. Only thing is that the dizziness and all which we said, any other neurological things which we have to look for. And if it is needed, we'll have to do an imaging of the brain, because you think of metastasis. Only thing I found, dizziness is the only thing which I found somewhere related to that. Yeah, I agree with Akhilesh. Yeah.
Okay. Now, this patient was asked for PET CT. I think she didn't have finances. She refused to undergo PET scan. CT was done. As part of a scheme, I think she was eligible to undergo this. It was done. Dr. Guha, you can comment on this. What do you see?
Sir, this is the axial section of a contrast enhanced CT scan of the upper part of the abdomen, showing a left suprarenal mass, which is well circumscribed. I have to see a little bit once more.
It is done. We can see. I'll play the whole thing. That's enough.
Yes, sir.
So how would you describe briefly? Important thing.
Sir, there is a left suprarenal mass which is well defined. Inhomogeneous attenuation.
Okay.
With
Yes, that's correct.
with no invasion or of adjoining structure. Peripheral fat planes are normal with the vessels, adjoining vessels, as far as could be made out.
Anything else you would like to look, suspecting that it could be a metastasis? What else you look at them?
Sir, I would look very well for the liver, if there is any liver
that was
lesion.
normal.
Liver
normal. Anything else you would look for?
Sir, opposite suprarenal gland, as you have said earlier, sir. And,
are you suspecting bilateral adrenal metastasis, which is common? Which is
no, sir, it's not common. No, it's not
so what
common.
would you look for? What else you would look for? Nodes?
Nodes.
Retroperitoneal adenopathy?
Retroperitoneal.
You would look for, correct?
Yes, sir.
Okay.
Did you find anything other in the CT? Anything else you noted?
Dr. Goa, this for you. Dr. Satish is asking you.
Another place, bone ERPR positive breast cancer after 5 years. The side of thing is bone mets, because some of the bone which we can see there, you have to look for the bone metastasis. Okay,
What
that is one. Second thing is there. Yeah. So second thing is there is a splenomegaly there. Okay, and liver is also slightly enlarged. I don't know why it is so. Yeah.
Yes, sir.
These are static images. CT was reported as a heterogeneous enhancing lesion of left adrenal with absolute washout of 40% and relative washout of 21%. Future suggests metastasis. That's what they gave it as. And a biopsy was advised for confirmation. There was associated cholelithiasis and splenomegaly were incidental findings in this patient. What would be the next approach?
Sir,
shall I go, sir?
Yeah, please.
I would like to again do a functional workup, sir. Send hormonal plasma metanephrines.
With a, you would like to do a biochemical testing.
Biochemical.
Okay. You don't want a biopsy.
Even before biopsy, I would like to.
You would like to. Dr. Guha, would you agree with that? You would like to do biopsy first and then biochemical first and then biopsy?
Sir, before taking any biopsy from adrenal gland, we have to rule out pheochromocytoma, sir.
You want to rule out pheochromo in this patient, okay? What would Dr. Satish say about that?
I agree with the examiners, because that is very important. Any adrenal tumor, though, before biopsy, I think one of the deadliest thing is a pheochromocytoma. So that is one, and because in around 10 to 12.5% of pheochromocytomas, that could be normotensive. So that's always there. So we'll do definitely I will do the biochemical evaluation, before doing a biopsy.
That was advised, which patient refused. Mammogram, X-ray chest and alkaline phosphates were within normal range. In this patient, biochemical markers were done before, but pheochromocytoma was not suspected, so they didn't send markers for pheochromocytoma. They checked for DHEA and then cortisol level, but there was no even suspicion for pheo. So yes, maybe it is a deviation from what is being agreed here by examiner. The CT-guided biopsy was advised and performed, and a complementary CT scan of thorax was done during the same procedure, which ruled out any pulmonary metastasis or pleural deposits. Biopsy revealed a malignant lesion with polygonal cells and abundant cytoplasm and trabeculae. Metastases were frequent. Histopathological picture was suggested as a primary adrenal tumor. It doesn't suggest a metastasis from breast cancer. IHC was advised as well as biochemical marker. So what should we do here? The pathologist said that it doesn't look like a metastasis from breast primary, looks like an adrenal primary lesion, malignant. And they asked for IHC. What should we do?
Sir, for IHC, we can do SF1 IHC, which is which confirms primary from adrenal tumors. So SF1 and IHC, and we can do the biochemical markers.
I would ask a very simple question for you. How do you rule out a breast primary from this?
Sir, we can do an ERPR.
That That would be a very simple answer, right?
Yes, sir.
You would want to rule out metastasis first,
Yes, sir.
correct? So you would ask for ERPR on the specimen. And she was a known ERPR positive patient,
Yes,
correct?
sir. Yes,
So
sir.
you would always look for a breast primary by looking at ERPR to rule out. Though the morphology doesn't look like a breast, you would still want to rule out, correct?
Yes,
What other markers? You said SF1, what else?
GATA. We can do a GATA. GATA 3.
Dr. Akhilesh, you would add up any other markers here in ISC?
Synaptophysin chromogram.
Synaptophysin and chromogranin. Okay, which suggests
Adrenal medullary origin lesion.
okay. So, sir, Dr. Satishan, you would add up any remarks on ISC? What exactly we should be doing?
Yeah. Cytokeratin, definitely. So as part of it. Then I think that's fine because we may not be able to differentiate, from malignancy from adenoma. These are things which we can say. Yeah. Yeah.
This was IHC done at our place. PAN-CK was negative. Chromogranin was negative. Synaptophysin was focally positive. Calretimin was positive. Inhibin was positive. Melan A, I didn't know what it was. It was positive. ER negative, PR negative. The impression given was adrenal cortical carcinoma based on the finding on biopsy and on IHC. And what do we do now in this case, Dr. Guha?
Sir, we have to complete the metastatic workup in this patient, sir. As she had done only CT abdomen. So we have to do a CT pelvis and CT thorax.
Now, CT whole abdomen was done. And thorax, I said it was done complementary when biopsy was done. It was negative.
Okay, sir. Then we have to do biochemical markers as it is a 4 by 2.5 centimeter tumor. We will have to operate this patient and we'll do a pre-anesthetic checkup in this patient, sir, as it is a carcinoma.
They checked these markers. Cortisol was within normal range. DHEA was within normal range. Urinary serum metanephrines were not sent as pheochroma was not being suspected in this case. It went like this. They were normal. So you would like to operate this case?
Yes, sir. We have to operate this case, sir.
Dr. Akhilesh, what is your opinion?
So I would also like to do MRI brain from a history point of view.
Okay.
Rule out any brain mets. And if there are no other sites of metastasis, and if it is adenocortical carcinoma, I would like to operate.
Okay. So we have come to a diagnosis of, yes, MRI brain was not done in this case, but because more due to there was no sort of real suspicion about any space occupying lesions in the brain. It was not done. So you would like to operate this case. Okay.
Yes.
How would you operate? What is your approach? Adrenal cortical carcinoma in a 7-year-old breast cancer survivor.
Would like to do a same pre-op optimization as like in a pheochromocytoma should be done.
Why would you optimize this patient like a pheochromocytoma?
Adrenal tumor could still be a silent intrapancreatic adrenal again can cause a
Patient
hypertension.
is not a hypertensive. There is no hypertensive crisis. BP is normal. Diagnosis adrenocortical carcinoma. So why would you like to optimize the way it is pheochromocytoma? Would the examiner agree with this?
No. We need not have to do it. There's no need for optimization here, no, because you're not thinking of pheochromocytoma. Okay. There's no hypertension. Any comorbidities that we can optimize, but there is nothing like that. So there is no need for that.
No need for any marker.
Yeah.
So
any specific optimization.
Yeah. Positive time. Yes, what would be the approach? Surgical approach? Open or laparoscopic?
Open adrenalectomy.
You want to do open adrenalectomy. Dr. Guha, would you agree? You would like to do open or you would like to do laparoscopy in this patient?
Sir, we open approach, sir.
You would like to do open. Sir, Dr. Satishan, what would you say?
Yeah. Yeah, classical thing is that open adrenalectomy for adrenocortical carcinoma. But even with experienced laparoscopic surgeons, and they can follow the same principles of the cancer surgery, and they can remove the adrenal gland. So that is also laparoscopic is also done, but it should be by an experienced surgical oncologist. That is it. But classical teaching is open. Yeah.
Yeah, classical teaching would be to have an open approach for reasons. Would you like to put forward some reasons why you would prefer open over laparoscopy?
Tumor seeding, peritoneal contamination.
Tumor seeding, okay. Contamination, okay. And anything more important or anything more additive, why open would be preferred?
No.
Would a intraoperative assessment would be more better in an open approach than in laparoscopy?
Yes, sir.
So the traditional teaching is to do open if there is a diagnosis of a confirmed diagnosis of adrenocortical carcinoma. That is what the evidence says. But as I think our examiner said, in experienced hands, I don't think they really are a contraindication, especially for a tumor of that size, correct? A large adrenal cortical carcinoma would be a tough thing to do laparoscopy. It may not be oncologically sound procedure. But a 4.5 centimeter well circumscribed tumor like that, it was operated laparoscopically and removed. And the adjoining nodes were cleared to see if they were harboring anything. All the nodes came negative. It came as adrenocortical carcinoma on surgery. Okay, so that was a diagnosis. Sir, Dr. Satishan, would you ask anything else for the student?
Yeah. I would like to ask, will you do any lymph node dissection or anything? Any systematic lymph node dissection in adrenocortical carcinoma?
Is there a role for a conventional lymphadenectomy in adrenocortical carcinoma?
Sir, there are studies, one retrospective studies which has shown that lymphadenectomy gives better progression-free survival. So, but there is still no standardization how to do the lymphadenectomy and what number of lymph node is required. So we can do a lymphadenectomy.
Yeah, at least we should pick up hilar nodes and the enlarged nodes we have to pick up. But there are people who do a systematic lymphadenectomy also. But as you said, there is no evidence to say that it is good or it's bad. So whether this is improves the survival or anything, only retrospective series are there. That is one. In what condition will you do a nephrectomy also along with adrenocortical carcinoma? This is my last question, sir.
Yes, yes. I think we would end with this.
Yeah.
When is a nephrectomy done in adrenocortical carcinoma? That's his question. Any one of you can answer.
The infiltration of the corresponding kidney en bloc resection to attain R0 margin,
Yes.
we can do a nephrectomy. Sir.
Yeah. Okay. Good.
Okay. I think we would come to the presentation end here. I think both the students did very well. I think 90% of everything you answered actually. That's really good.
Yeah. Is
Dr.
Ganesh,
we end our. Thank you very much, Dr. Satish.
Yeah.
Thank you.
Thank you.
Thank you. It is over to you.
Yeah.
Thank you, Professor Ganesh and Professor Satishan, for that excellent mock exam of Dr. Akash Guha and Dr. Akhilesh. Both did fantastically well. We move on to our next segment, which would be the expert talk by Professor Satishan. So while Professor Satishan loads his screen, I'll request Professor Ganesh to kindly go through the chat and the Q&A. And while the expert talk is going on, if you can address some of the questions, we'll discuss a few of them in the end. Over to you, Professor Satishan. Would you
Sujan, Dr. Sujan, thank you very much. I think you have to close this particular slide. Then only I can share it.
We'll do that.
Yeah.
I need to close it.
Yeah.
I think
Please
I've
go ahead.
done
Yeah. Yeah. Now, shall I share now? Yeah.
Please, sir. Please go ahead.
Yeah. Can you see my slide?
Yes, sir. Not full screen yet.
I'm making it full screen. I think. Yeah, is it full screen now?
Yes, sir. Yeah, please go ahead.
Yeah, only just check that whether it moves. Is it moving?
Yes, sir. It's perfect. Yeah.
Okay. First of all, let me thank Professor Subramanish Rao and Dr. Srijan and the president of IASO and Professor P.K. Das for giving this opportunity. And to confess, for the first time, I'm joining this IASO Masterclass. So it was an excellent experience for me. And I extend my sincere thanks and gratitude to Professor Ganesh for doing this, the examination so well, and so that I hope it would be beneficial for the postgraduates. And let me come to my talk. Today, I'm supposed to talk about adrenal tumors and some contemporary management and some controversies, if any. So I just go through some basic anatomy, and we know that's a paired organ, retroperitoneum. It's an adrenal. It is a hormone-producing organ in the body, and it's covered with the renal fascia, and it has got a good connective tissue capsule, and it has two embryologically distinct tissues. It has got an outer cortex and inner medulla, and cortex has three concentric layers: zona granulosa, zona fasciculata, zona reticularis. These produce different types of hormones, mineralocorticoids, then corticosteroids by the fasciculata and also by the reticularis. And adrenal medulla is originated from the neural crest, and it has got chromaffin cells, and it produces epinephrine and norepinephrine. So adrenal tumors, for surgical oncologists, how it is important, because an incident is something which a term very commonly used. It is an asymptomatic adrenal mass detected on imaging, not performed for detecting any lesion in the adrenal as such. So this is something. So because of the incident it's around 5 to 7% in the cross-sectional imaging, but done for other purposes, we find certain adrenal tumors. So if you take it for broadly, we can consider it as 5 categories. One, it may be adenoma and nodal hyperplasia is one category. It could be functioning or non-functioning. Some other benign lesions like myelolipomas, cysts, and hamartomas, etc. Adrenocortical carcinoma and some other malignant tumors, they are rare. It is mainly the metastasis, sarcomas, and lymphomas, and pheochromocytoma. So the generally looking at this, the malignant adrenal tumors is only around 8.6% of all cases of adrenal tumors, and majority are mainly metastasis. So the two tumors which we are going to discuss now is adrenocortical carcinoma and pheochromocytoma paraganglionoma. So in adrenocortical carcinoma, it's a rare tumor. It's 0.5 to 2 per 1 lakh population, and actually there is a slight female preponderance. It has got bimodal age distribution, and the no definite etiological factor is known. But there is a genetic factors involved in it. Around 15% of adult ACC and 80% of the pediatric ACC have germline mutations. So the hereditary syndromes which we have to know are 15% adult ACC, germline mutations are found, which are related to Leaf-Romney syndrome, Lynch syndrome, MEN type 1, familial adenomatous polyposis, Beckwith-Wiedemann syndrome, and Carney's complex. And this is something which I think the postgraduate should remember. And the pediatric ACC is different. Here, the 80% of the tumors do have P53 mutation, germline P53 mutation. Symptoms and signs of hyperhormone activities, and that is something which is we have to look for, and especially in Cushing syndrome, there will be obesity, diabetes, headache, hypertension. This is found in Cushing syndrome and Conn syndrome and virilization, and very rarely we find feminization. So these are some of the symptoms which we have to look at it in the case of adrenocortical carcinoma. Interesting thing about adrenocortical carcinoma and hyperactivity is that those patients with high glucocorticoids, those ACC with high glucocorticoids, a high chance of malignancy. High chance of metastasis. Adrenocortical carcinoma, all patients with suspected ACC, they should have a comprehensive endocrine workup. This is something very important because some tumors, though they may not produce an excessive, may not any clinical features, but still it may have a subclinical elevation of hormones. And the standard imaging is CT chest and MRI under this one. So I'm coming to that. What are the why we want to do hormone evaluation? Hormonal evaluation, any adrenal tumor for that matter. One, it produces an orientation. What is the nature of the adrenal mass and what gives? Second thing is that pheomocytoma is important because if you are in a case of metastatic disease, you're suspecting metastasis, you want to do a biopsy, that is important. Massive corticosteroid excess, sometimes it will have a short-term survival, it might have quality of life is affected. And abnormal hormone secretions, again, at a biological marker, especially when you follow up the patient after treatment. So generally for adrenal cortical carcinoma, how the evaluation goes, if you are suspecting a subclinical lesion, you do 1 milligram dexamethasone suppression dose, 1 milligram from the previous night, and next day you check for the cortisol, and if it is the more than 15 microgram per deciliter, generally it rules out cortisolism. And similarly, look for the other hormones, DHEAS is for sex steroids, and also ACTH level, baseline ACTH level. Then mineralocorticoid exercise, mainly the potassium we have to look for, aldosterone ratio. Then if you have adrenal tumor, any evidence of metastasis, yes, we do a CT of the abdomen, pelvis, and chest, and FDG PET if it is indicated. Then MRI, brain and cerebral symptoms or something is that. This is how the workup goes in the case of adrenocortical carcinoma. So imaging, again, I said, it's a non-contrast CT scan because during the discussion, we said some adrenal tumor, we want to rule out because adrenal adenoma is the most common adrenal tumor. So we want to rule out adrenal adenoma. Non-contrast CT scan, it shows that Hounsfield units is less than 10. So then that is one thing, it shows that it would be and it should be a homogeneous mass. So we can take it as a lipid-rich adenoma. But again, the Hounsfield units also give some indication of whether it could be malignancy or benign. If it is less than 10, it is usually the benign is almost, the chance of malignancy is almost 0%. And this is when between 10 and 20 is around 2 to 5%, and more than 20 is around 10%, and 10 to 20%. MRI, FDG PET, other investigations. So in benign tumor, this is something which we should know. The single best criterion to benign tumor is a Hounsfield unit, 10 or less on non-contrast CT, then rapid washout. That is a very important thing. This is how we diagnose between a lipid-rich and lipid-poor adenoma, and single intensity loss in opposite MRI. Then FDG PET is usually negative. Adrenocortical carcinoma, imaging, non-homogeneous appearance in CT or MRI, irregular margins, irregular enhancement of solid components, especially after giving IV contrast, then really slow washout in contrast CT. It might show certain features of local invasion or tumor extension into the IVC as a thrombus, then lymph node or other metastasis. It may be usually it's a lung and liver seeking tumor, and increased application, FDG PET. So preoperative biopsy, should we do it or not? Generally, it is contraindicated. The simple reason is that the risk of tumor spillage is genuine, and poor diagnostic power, because it is difficult to diagnose malignant and benign adrenocortical tumors. And there is no single marker to say that, no, this could be malignant. So the risk of a hypertensive crisis in pheochromocytomas is another important reason why we do not want to do a biopsy. The indication for needle biopsy, adrenal mass, no hormonal excess in patients with a history of extra-adrenal cancers. Yes. To prove or disprove an adrenal metastasis. Yes, in certain experimental areas and probably in non-secreting tumors, we might do a biopsy and tumor sequencing. In pathological diagnosis of malignancy is that histological differentiation between adenoma and disease is extremely difficult. There is some criteria which the pathologists do that. That's WISE criteria. There has been 9 parameters. A score than 3 or more than 3 is likelihood of malignancy. ISC is that, as is inhibin alpha and calretin and melan A. So there is a staging system. This is in a span and AJCC staging system. It's based on the tumor size, 5 centimeters or less, and more than 5 centimeters T2. T3 is any tumor with a local invasion, but not invading adjacent organs. T4 is involved with the adjacent organs. Lymph node plus or minus N0, N1. If you look at it, stage 3 means node positivity or T3 or T4. And in the case of the metastasis, it becomes stage 4. So the management we have evaluated. We found this an adrenocortical carcinoma, and because it's by the tumors, the clinical and radiological and biological suspicion, so we go for the surgery. The principle of surgery is often classical thing is often transperitoneal approach. There is no difference between transperitoneal and retroperitoneal approach. Arso resection is our aim. If local invasion is there, we have to do an en bloc resection, or sometimes we have to do a multi-organ resection. No spillages is the principle, and the role of lymphadenectomy is still unclear. We can at least we have to resect the nodes around the hilar and peri-adrenal areas. Then routine resection of kidney is not needed. If there is a definite infiltration of the kidney, yes, we have to do a radical mastectomy along with that. Open versus laparoscopic. The contraindication for MS is one, there are with an experienced hands, definitely laparoscopic adrenalectomy can be done for smaller tumors. But if any evidence of local invasion, large size tumors, and expeditious surgeons, these are the general contraindications for MIS. Postoperative adrenal insufficiency is one of the things which you have to, especially in a functioning tumor, hypersecreting tumor, or if it's a bilateral tumor. When you do a bilateral nephrectomy, patient will go for adrenal insufficiency. So these are two conditions which we have to worry about in the case of postoperative adrenal insufficiency. So we have to take measures to prevent postoperative adrenal crisis. In such cases, you have to give corticosteroids postoperatively. And there are certain situations, especially those patients with hypersecretion, as I said earlier, especially with increased secretion of glucocorticoid and adrenocortical carcinoma, it is a sign of potential for metastasis. Adjuvant therapy, nearly 50% of the adrenocortical carcinomas do recur. So hence, adjuvant treatment is actually advocated. So what are the conditions in which the adjuvant treatment is given? One drug which is given is mitotane. Mitotane, one problem is it's a narrow therapeutic index, it's a long-acting drug, and it interacts with the chemotherapeutic agents also. So there are a few multicentric studies, case control study to meta-analysis shows that an improvement in relapse-free survival and overall survival with mitotane. But as per the guidelines, European Society of Endocrinology and NSAID guidelines, it is actually the patients at high risk of recurrence which you have to take. That is stage 3 or R1 RX resection or Ki-67 indexes is more than 10% and should be offered adjuvant mitotane. But in stage 1 or stage 2 disease, it is individualized. It's a shared decision making. So histologically proven RC resection, only thing if it is Ki-67 is expressed in 10% of neoplastic cells, these patients probably you can think of giving adjuvant mitotane. And how much duration we have to give mitotane is at least for 2 years, but definitely there's no indication of more than 5 years. Adjuvant radiotherapy, again, and this is only in stage 3 close or positive margins, you can consider if there is local infiltration. And only improvement, it shows that some improvement in local recurrence. But one of the problems of adjuvant radiotherapy, because this organ is very close to kidney and liver, so the dose to the constraints have to be really worried of. But with the modern radiotherapy technique, it is adjuvant radiotherapy can be given in select situations. Now I go to the adrenocortical carcinoma and prognosis. In clinical stage 1, stage 2, the 5-year survival is around 90%. It's completely resected. In stage 4, it is only around 15 months because it's an aggressive tumor basically. And the reliable prognostic factors, because unlike other tumors, it's a rare tumor. So we don't have big randomized control trials. Most of the things as retrospective studies. So we have the important prognostic factors on stage of the disease, R0 resection and Ki-67 index, glucocorticoid excess. And these are the main prognostic factors. These high Ki-67 indicates high chance for metastasis and glucocorticoid excess too. In a case of ACC, if an advanced metastatic disease where surgery is not possible, so usually the prognosis for 5-year survival is less than 15%. Here, the goal of treatment in unresectable, locally advanced or metastatic ACC is one, how to control the tumor growth, then hypersecreting symptoms, whether we can reduce it, then we can prolong the survival. So the first line therapy is mitotane alone or mitotane plus chemotherapy. Or in the case of sometimes, we may be able to do some debulking surgeries in certain situations. So in addition to systemic treatment, in certain population we can do. Hormone excess, overt hypercorticolism, it may lead to immunosuppression and uncontrolled diabetes and muscle weakness. This is one of the reasons why sometimes we go for surgical debulking. Medical therapy to control hormonal excess is also recommended. In such cases, we can use metarapone or ketoconazole, and apart from mitotane. Now coming to the pheochromocytoma. Pheochromocytoma is a catecholamine producing. It is arising from the chromaffin cell, and it is related to extraadrenal sympathetic and parasympathetic paraganglioma. So then it's called as a paraganglionoma. And pheochromocytoma constitute around 80 to 85% of these tumors. And generally, pheochromocytoma, paraganglionoma are clubbed together in sizes. Pheochromocytoma, paraganglionoma. So original description of this particular tumors is during our young days, and this is used to be a classical 10% tumor. Now it is invalid. So pheochromocytoma, paraganglionoma, the incidence in the general population is 0.05%. 30% of these patients do have germline mutations with familial syndromes. So that is MEN type 2, von Hippel-Lindau disease, neurofibromatosis type 1, pheochromocytoma, paraganglioma syndrome, and 1 to 5. Sorry, this is germline mutations 30%, but this is the familial syndrome, leiomyomatosis arthritis syndrome, and syndromic pheochromocytoma, and these are the some of the the familial syndromes is known of, and 25% of all pheochromocytomas are malignant. 50% of the paraganglionoma type 4 syndrome has got malignancy. So PPGL, this is the acronym used for that. All patients with suspected paraganglionoma, pheochromocytoma need to have a measurement of plasma and urinary metanephrines. Plasma for urinary fractionated metanephrines, we have to look at it. And the suspicion of the disease is primarily based on one, presence of symptoms, signs, manifestations of presumed catecholamine excess, incidental adrenal mass, any routine screening for due to high-risk features or hereditary predisposition in such cases. So there are certain patients, we consider as a high risk for metastasis. And there are generally the imaging is as conventional radiology imaging to look for any metastasis, because presence of metastasis is the only sign of malignancy. And all pheochromocytoma, paraganglionoma has to be considered as potentially malignant. And we find the important thing of metastasis is that those tumors should be in a place where we do not normally find chromaffin cells. Then we got, if already occurring in a place where chromaffin cells are already present, they are generally considered some maybe multifocal diseases. High risk for metastasis in any patient with one of these following criteria. Only adrenal pheochromocytoma 5 centimeters or more in size, yes, there is a high risk for metastasis. Any extraadrenal paraganglioma, yes. And known SDH beta germline mutation is considered as yes. There is one biomarker, recently evolved biomarker called plasma methoxytyramine. And if it is more than 3 times higher than the upper limit of the reference value, yes, this may be considered as potential for metastasis. In this type of features, if it is present, and probably there's a whole body functional imaging may be justified. So these are the investigations generally done. It look for catecholamine excess, that is fraction metanephrines. Any extension or renal tumor CT imaging studies we have to do. Evidence of bone metastasis or any suspicious, for example, elevated alkaline phosphatase, FDG PET or dot-net PET CT. In those cases, especially those patients, we characterize as high risk for metastasis. So these are things which we have to do the imaging. One of the reasons why we wanted to do FDG PET or dot-net PET CT is that because it might be useful when patient develops metastasis at later stage. So pathology is that indicators of pathology as for the tumor size is concerned. This is one I said already. Yeah, and now coming to the management, surgical excision of the tumor is the first line treatment. Either laparoscopic or minimally invasive surgery is a common technique which is used. Local invasion is generally rare, and hence the rupture of capsule is rare when compared to ACC. And dissection should be complete. That is very, very important, whether it is a laparoscopic approach or an open approach. Perioperative preparation is vital in the case of management of a pheochromocytoma. The aims of perioperative preparation is that 1, control the hypertension, 2, vascular expansion. The hypertension in a functioning pheochromocytoma has got 3 types of hypertension. One could be a paroxysmal hypertension with a baseline normal blood pressure. For example, if you check the pressure, in between patients' blood pressure may be normal, but she gives a paroxysmal hypertensive episodes, or baselinely elevated blood pressure. Blood pressure is elevated, but intermittent paroxysm. Sometimes in some patients, there will be persistently increased blood pressure. This is another 3 types of hypertension seen in the pheochromocytoma. So preoperative target, yes, you have to look for you have to bring the blood pressure to a supine position. It should be less than 130/80. Systolic pressure on standing position should be less than, at least more than 90 millimeters of mercury. And pre-operation and preparation for at least 10-15 days is a minimum period which is needed to prepare is 5 to 6 days. But generally 10 to 14 days is safer, and careful titration of drugs is very important. And the control, because these are the drugs which we already discussed on that, phenoxybenzamine and prazosin and the side effects with these things which we discussed. And alpha-2 receptors actually, because prenascentral noradrenal is non-inert, so that produce severe tachycardia is actually less with the selective alpha-1 blockers. So these are the drugs: prazosin, doxazosin, terazosin, and we have to start with small doses and titrate it until the blood pressure is controlled. So beta blockers and calcium channel blockers are used when there is still the blood pressure is quite high and tachycardia is there. In such situations, we use beta blockers. Still, if it does not control, then we can add calcium channel blockers. Vascular compartment expansion is that we have to tell the patient to take at least 2 to 3 liters of fluid with 5 to 10 grams of salt to increase intravascular volume. If it is still not improving with that, probably we'll have to go to IV fluids. And one of the methods by which how we titrate the intravascular volume expansion is that the fall in the hematocrit value of 5 to 10%. So, and at least in May 5 to 15% of prior preparation with the beta blockers, alpha blockers and beta blockers. Very important thing is that without alpha blockade, we should not use beta blockers. It can produce pulmonary edema and also ischemia of the heart. Intraoperative, very important, very safe and experienced anesthesiologist is the most important component there. And there may be rapid intraoperative hemodynamic lability is to be expected. So we should be aware in what are the situations we'll expect hypertensive crises while intubation, even touching the tumor and all these areas, we should be very careful. And it's when you do laparoscopically, when you insufflate also the BP can go up. And especially when patients have received opioids and benzodiazepines, when intraoperatively used, it can produce a hypertensive crisis. So during hypertension, we should have certain drugs with us. There is this magnesium sulfate and phenterlamine and nitroprusside, sodium nitroprusside, nitroglycerin. So these drugs should also be available in the OT. Tachycardia has to be treated with beta-adrenergic receptors, esmolol. And postoperative hypertension is expected, and it should be prevented by saline infusion. Should be very, very careful. Hence, the arterial line and central venous catheter, etc., very important prerequisites. Post-op again, post-op management usually requires an intensive care thing. And once the tumor is removed, it produces hypotension. It might need vasopressor infusion and fluid infusion. And another problem is that once we remove the tumor, there will be hyperinsulinemia. Rebound hyperinsulinemia produces severe hypoglycemia. So in the postoperative period, we have to check the blood sugar and manage accordingly. So in metastatic pheochromocytoma paraganglionoma, the objective one, in metastatic disease, there is no curative option available. It's all tumors are resectable. Yes, we should go and resect it. In oligometastatic disease, if extensive disease unresectable, actually there is no curative treatment option. Our treatment is mainly how to reduce the symptoms. Few options are available. Watch and wait policy. In case asymptomatic patients, we can avoid doing anything. Or local regional therapies, which we can consider, including a debulking surgery, radiopharmaceutical agents, which we can use, and systemic chemotherapy. And recently, molecular targeted agents are also used. Active surveillance, in the case of metastatic things used is asymptomatic patients, low to intermediate tumor burden, and there is no evidence of any localized complication by the mass. Surgery and local ability is a debulking surgery in improved symptoms, and we should be careful. Then another method, local repression, SBRT can be used, RFA, chemoembolization, these are other methods. Radionuclide therapy, yes, MIBG, 131 is one most frequently approaches on radionuclide basis. Another one is that we can use daughter tape scan and the 668 gallium, or it's this lutetium-177 labeled. This one can be used in those tumors in which pick up this radio traces. Systemic therapy, systemic chemotherapy, cyclophosphamide dacarbazine-based chemotherapy has been used. And among target therapy, sunitinib and pasopanib are the drugs which have been tried out. So this is about the just algorithm which is said. Now to conclude, these tumors are rare. And the problem is that these tumors are functioning tumors. So, and this is difficult to preoperatively, it is often difficult to find out whether it is a carcinoma or adenoma or it is a pheochromocytoma. So we need to have a preoperative evaluation. It should be thorough, biochemical evaluation, and perioperative management is crucial, being an endocrine organ. And multidisciplinary teamwork is vital in this case. And thank you very much. And thanks to Srijan, Professor Subramanish Rao, Professor Ganesh for giving this opportunity. Thank you very much.
Thank you, Professor Sathisan. for this comprehensive talk, which, although this topic is rare, there's so much literature on it, and sir has nicely covered almost all the topics in the subject. If the residents feel that it will help to go through his talk again, you could do so on YouTube later on. This brings us to the final segment, which is the Q&A. And I think a lot of these questions have already been answered by Professor Ganesh on the chat box. I've chosen a few which we'll address before concluding tonight. The first was, I think, what is the contemporary indications for MIBG or radionuclide scans? And I think Professor Sathisan addressed that in his talk. So I'll rather pose this to Professor Ganesh. Sir, in which patients should we go for radionuclide scans?
I think it was very clear that we do it only in case of doubts. If we are not sure about the diagnosis on functional imaging, functional assay, or if the values are marginal and then the diagnosis is in doubt, then we use these scans. MIBG is not now commonly used after the other radiopharmaceuticals are available. And as Professor Sathisan said, we also use it when we suspect metastatic disease. When we suspect spread, we want to do these nuclear imaging. So that is about indications for MIBG.
Right. We'll go to the next question. Is it mandatory to visualize and safeguard renal artery, specifically upper polar arteries, before clipping any adrenal vessels? Professor Sathisan.
Generally, I prefer to do that because upper polar artery, because one thing is that, that will be because we are taking the tumor off the kidney. We don't want any upper part of the kidney necrosis. But generally, I did not go for a very thorough search for the small upper segmental artery. But generally, we look for it. That is one. It is. I don't say it is mandatory, but generally, as a practice, we do that. That is one.
Right. Professor Ganesh, anything?
Yeah, but I don't think we routinely search for those. But I think CT imaging, we do look for any sort of anatomical proximity to the tumor of the thing. But otherwise, routinely, no. Once the vein is clipped immediately and then we lift, once we lift the adrenal, I think it is close to the adrenal, you take it out.
Right. Next question is, are there differences in approaches to right versus left adnectomies, and how do we manage the pancreas and spleen for the left adnectomies? Professor Ganesh.
Yeah, I think that's a very good question, because I think the most important thing is to, once we you want to get a good access to the left adrenal, I think the pancreas and spleen have to fall down. Okay, I think you incise the attachments and then let the gravity get the pancreas and spleen down. Once that happens, I think you have unlimited access to left adrenal. That's the most important step.
Right. Professor Sathisan, anything to add?
No, that's I fully agree with him. I agree with him.
Right. Our last question was not here, it was on YouTube actually, and it was if we have a single or limited peritoneal met with adrenocortical carcinoma during exploration, should we still go ahead with curative intent surgery or call it a day and come out?
I would call it a day.
It's a difficult one. That's one of the principles is that an ACC with oligometastatic disease, yes, resection is accepted and indicated also. So single peritoneal disease, yes, I would do that. Simple reason is that one, it would reduce the hypercortisolic actions. So I don't know whether it will produce any cure the disease or anything, which I cannot say because it's a peritoneal disease. But as a general principle, yes, I will go with the adrenalectomy with a single peritoneal disease, or maybe a very limited peritoneal disease in that.
So, Professor Ganesh, would you agree that if the patient has symptoms, maybe you would consider?
Only for functional, but otherwise, with the metastasis, even if it's single, I think outcome is very poor. Very poor. If it involves a major procedure, I would rather think twice for that.
So I think these were all the Q&As which we had left from the audience. I would really like to thank Professor Sathisan and Professor Ganesh for being very patient in today's talk. Tumors are rare. It would not be frequent that the residents might get a chance to learn these tumors in all the centers. So it really helped that the pace of the whole webinar was very relaxed, and I'm sure the residents will go back and revisit some of the segments of the webinar to gain more clarity. Thank you, Dr. Ganesh.
There is one question, Dr. Shukla, from Dr. Raja Bhagat. CECT with IV contrast was supposed to document release of catecholamine. So what is the consensus on that? I mean, I would say that it is not really anything which is very common or which we worry about.
Yeah.
It may happen, but it's not something which is coming in the way of doing a contrast CT in these tumors. That's my opinion. Dr. Satish can put it.
Yeah, definitely. I agree with you. Because that is not something which, to be frank, I have not come across. Anyway, for that, I think,
So coming back to my concluding remarks, especially would like to thank Dr. Ganesh, because he was quite prompt in preparing these slides, sending them to us and Dr. Satishan, and doing a fantastic job. Thank you so much, sir, for taking up the time and effort.
Thanks for
thank you.
Yeah. Professor Satishan was really wound up today at a government meeting, and we were not sure whether he'll be able to join, but he did. He had promised me that I will join, and joined. He did, and the webinar became so much better because we had two examiners, both seniors, and the topic got discussed in detail. Thank you so much, Professor Satishan, for joining in.
Okay, thank you.
To Akhilesh and Akash. Thank you for volunteering. The examiners might not know this. All the students that we are having on from the second series onwards, they are all volunteers. We have not coaxed any one of them to join in. They are volunteering to come ahead and preparing and getting exposed to the national audience. So thank you both of them for volunteering.
Thank you, sir.
Thank you, sir.
Yeah.
Thank you, sir.
Thank you very much.
We would like to thank our President, Dr. P.K. Das, and Dr. Chandramohan, our Secretary, for continuing to support us throughout this masterclass series, our advisors, Dr. Arnav Gupta, Dr. Sadashivam, Dr. Rajgovind Sharma, and Dr. Sanjeev Mishra for their continuous guidance. And lastly, to Dr. T.S. Rao, sir, to envisioning it and, continuing to really push us to finding topics and completing those topics. Rarer, the better is where we are these days. So thank you to Dr. T.S. Rao. With that, I would like to close the webinar for tonight, and we would meet again in a fortnight's time, Tuesday 7 p.m. With another webinar. This is all from the Academic Council of IASO. Thank you so much for joining in. Good night.
Thank you very much. Good night.
Good night. Thank you. Good night.